accurate word would not be totally against, but I believe that BCG induction plus maintenance has an important role and will still have an important role in the upcoming years. It is true that there are two new trials, the CREST and POTOMAC trials, which are positive and have shown that the addition of systemic immune checkpoint inhibitors increases the response rates as compared to BCG induction plus maintenance alone. So that's why BCG will still stay with us, because there's the need of BCG induction plus maintenance along with the immune checkpoint inhibitors. However, there is a very small magnitude of the benefit and an increased risk of adverse events. We have a number needed to treat of around 3 to 5 and a number needed to harm of 15-20 patients. So we should be able to select the patients who will benefit most from this combination. We know that the high-risk non-muscle invasive bladder cancer setting, as described in the trials, is very wide, is very heterogeneous, and some patients, like maybe those with a high-grade TA solitary tumor, won't benefit from this combination. So the challenge is really to identify those patients at a high risk and who will have more benefit from the combination of immune checkpoint inhibitors plus BCG.